Very good evening to all. Coming towards the end of 2 days of COMPLICON, we shall end up with this panel discussion. So I will be presenting two oncology cases pertaining to ablation. Followed that, Dr. Radhika will be moderating the panel for reconstruction. So I have put two clinical scenarios which are seen commonly during our OPD days, but not very common also, right? So to start with case 1, we have a 48-year-old male, ECOG1, good PS. He is a smoker. He is diabetic on OHAs. He had a right buccal mucosa and RMT lesion extending to medial pterygoid, low ITF disease. But unfortunately, he had a very high nodal burden. Bilateral necrotic nodes with evidence of many radiologically positive ENE nodes. Thorax no disease clear. So T4B and 3B M0. So in view of high nodal burden in all levels, including level 4-5, we challenged him with NACT, 3 cycles of TPF, which he is tolerated well. So he came with a very well regressed primary, but nodal status remained almost same. So the case goes like this. So he has a multiple necrotic nodes. If you see both 2 necrotic nodes in intraparotid nodes and a big level 1B node with soft tissue mets. So my question to the panel: does the multiple necrotic node, should we decide against surgery? Dr. Shiva sir?
I don't think so. This is a decision that we should take. What we need to think is, if it is resectable, we should go ahead with surgery. But we know for a fact that this is an advanced disease. The prognosis is not good. So instead of adopting the routine path, we would have also done the same thing. We can probably give him NACT, look at the response, and then go ahead with surgery. NACT is just given for the fact that because it's such a nodal burden is so much. So, and that too, it's a lateralized buccal mucosa with bilateral necrotic nodes. So that means it's a bad disease, and that's why we want to challenge with NACT and then see. Definitely, we cannot rule out surgery for this patient until and unless it's an unresectable disease with the various things that we have discussed so far.
Sir, Kranti sir, what's your?
I don't agree with the same thing. If it is operative, we should go ahead and operate.
So the take-home message is, even though the primary has regressed well, but the nodal burden is too high, that should not.
Only thing is that we should at least do a PET scan for this patient before considering anything else, because we didn't see the PET scan. With so much of nodal burden, we have to rule out distant metastasis.
Yeah, so I had mentioned the previous. So thorax, everything is clear.
Meaning we have to do a PET scan.
Yeah. So after now this 2 cycles have been given. So again we should repeat the scans and then go ahead with
assessment
surgery.
scan.
Yeah,
Assessment scan for definitely yes. But before we plan the intent for such nodal burden, distant metastasis workup should be a minimum PET scan. Is what I feel.
Siva sir, how often in your practice do you give NACT for high nodal burden, or have you found it to respond actually? Like more of what we general dictum, what I feel is depending on the primary we decide whether NACT.
If this was tongue or buccal mucosa, it's the same situation. Only thing is, if it is resectable up front, we go ahead with surgery. But this patient, we know very well for a fact that whatever we do, this patient is going to do bad. So that's why we want to give NACT. And this patient is highly likely to fail with distant metastasis. So that's why maybe NACT. So, we know also for a fact that the nodes don't respond as well as the primary, which is also reflected here. So we have to counsel the patient and then plan treatment.
So the take-home message is, the NACT is just not about technical inoperability or borderline of inoperability. Even nodes come into play, whether the decision to go ahead with NACT. So second thing would be, if the node has gross ENE with a grade 3 soft tissue metastasis, does it give us a red flag, surgery versus CRT? If the node is fungating outside through the sternocleidomastoid and the node has come out, so should we again rethink, or should we just go ahead with surgery itself? Ratan sir?
I agree with the previous whatever was told.
If it is surgically resectable, always resect. The best form of best survival is with surgery followed by adjuvant in oral cancer across all series. That is.
Yeah.
Now, if it is an extensive nodal disease with fungation and you know that prevertebral is involved, I don't know, I mean, could not see the scans very well. If you are not sure of removing the node in toto, with margins, then I don't think we should do it. If you are able to dissect the node off very well, if prevertebral is not involved, the great vessels are not involved, you cannot leave behind disease on great vessel or prevertebral with poor nodal clearance. If you can remove clearly, maintain the facial planes, then only you should go ahead.
Well taken.
Again, here you need to understand the trial resection. You are planning for a trial resection. You have the primary, which is also a trial resection. Even the node, again, you are showing it to be a trial resection. Both things cannot be. I think you have to sit with your radiologist and find out. How is the planes with the carotid and how is this. Even that, what you showed the
so
scan.
then these great vessels come into play, whether the decision making of whether the great vessels are involved or not.
Yeah, I think I echo what Kranti said. Both cannot be trial resection. We need to be very certain clinically and radiologically as to what is the resectability, and especially the nodes, whether there is involvement in the prevertebral fascia. What is the relation to the vessels? Is it more than 180 degree, 270 degree? All these things will matter when you take the decision as to whether you want to go ahead with surgery or take a non-surgical treatment. If there is fungation of the node, I'm not sure how comfortable a radiation oncologist will be giving concurrent chemoradiotherapy. So it's not between surgery versus radiotherapy. The intent is whether it's curative or palliative. Yeah.
The at least one vein has to be preserved for the resectability. He said he has got a bilateral neck node. Suppose if the opposite vein, if you are not in a position to preserve, what is the point in operating?
Yes,
exactly. So if during the surgery you're doing neck dissection on one side and you see that the node cannot be resected until you sacrifice the vein, I think you shouldn't sacrifice the vein at that point. You just have to stop, go to the opposite side, make sure you save the IJV. If you're able to save it, then come back and complete your surgery. Otherwise, for a squamous cell carcinoma, it's a very poor prognosis. If you have to resect IJV and also if you reconstruct, it's a high risk for the patient.
Also, I'd like to reiterate what Prathamesh Pai sir said yesterday. When we are performing trial neck dissection, we have to ensure with the degree of carotid encasement. If it is less than 180 degree, we need to ensure whether we are able to get the stump below and above. So we need to start the dissection from medial to lateral initially, ensure that the carotid artery is free, and then proceed with the neck dissection.
Right.
The main point is that the ability of us getting an R0 resection. If you are able to get an R0 resection here, and if you are able to do an adequate reconstruction, then we should go ahead. And Manish sir,
Dr. Manish Mayer sir from UK, any comments from your side?
Yeah, I think everybody has said what is required. I think PET is important because it has shown 34% change in the management in these cases. Also, I think I would just add that in UK the role of NSCT is quite limited. So if it is operable and if PET is negative, we would just operate the case and give CDRT after that. The thing is that we have to understand that in both the scenarios, the survival is not going to be that good. So on an average, the survival for such patients is 1.5 years. That is based on the NACT paper by Vijay Patil from Tata. So 18 months is the survival. So I think there's no right and wrong answer. We should understand the prognosis is poor. But I think in UK per se, we operate these cases upfront rather than doing NACT and then surgery.
Right. Thank you, sir.
So how much skin margin would you be taking in this?
For the node?
For the node or for the primary?
For the node, soft tissue.
Manish, go ahead.
You can tell for both, sir.
Yeah, I think 1 centimeter margin as usual than anything else. Yeah.
Actually, it's a misnomer. For a node, you're taking a margin on the exterior, but it's 180 degrees encasing the internal carotid. You will not be able to take a margin there. So it's just that it's a placebo margin for the surgeon, but not for the patient. And so you just go ahead and resect, and the trial resection is easier said than done. Because many a times you have to read the scans very well and take a leap of faith. It's many a times that has been my experience, and you will have to commit and then go in and then try to get it out, because it's not as simple. You just go in, oh, it's unresectable, and come out. In neck, it doesn't happen like that.
Right. So many of the times we have to commit the whole incision in order to get the exposure to the carotid,
Yes.
because of the sometimes it will be the skin which is ulcerated, fungated. So the tissues will be so bad to dissect, and we have to commit the entire incision.
Yes. It's not you open, see, and come. No,
So
that
there's
doesn't
no
happen.
Coming back.
Now for the primary you have the something what we call induration, we palpate and all. But when it comes to the node, at least you should see the pidu orange in around the skin and
Skin
all.
changes of
Then you
lymphatic.
can go ahead
Take
and take the
margins,
margins.
So these two papers I just want to bring to attention. The diagnostic challenge, the paper from Hisham Mehana group, they have explained what is extranodal. This is for basically for the fellows and postgraduates. This is a good review paper. They write in detail about the extranodal extension and the nuances about it. Another paper from Hisham Mehana group, latest publication in Lancet. They have brought up a guidelines for extranodal extension and what are the recommendations for each. So they've explained into no ENE, minor ENE, major and soft tissue metastasis. So again, we know the cutoff of 2 mm and more than 2 mm. So just to bring to your attention. So again, just to show what is a soft tissue node with a soft tissue metastasis, this is what it means. You know, it's almost getting fungated and almost coming out and invading all the trapezius muscle and everything. And this is a grade 2 ENE. So my next question would be a level of lymph node with ENE. Does the level of lymph node with ENE influences the decision making level 1B versus level 4? Let us say ENE node with a level 4 and level 5.
Yeah,
Right.
it's a great question because we abandoned the surgery a
Exactly.
month back with the T1 primary tongue. With the which was, see, whenever you assess a T1 primary, you always look for the level 1B, level 2, level 3. You hardly look lower down. But this is for all the residents. There was a miss in the chain of assessment. Nobody saw for level 4 metastasis. Level 1B was involved in this case. Level 2 was not involved. Level 4 was involved. And it was unresectable, reaching up to subclavian vein, which was there on the scans. It is a mistake on our part that we have not visualized it.
So these are
Nobody
very
accepts
important
these kind of mistakes, but I am accepting it. This happens. Okay.
So what
We
happens is
abandoned the
as we go ahead, there's no point of coming back. Right now you have committed the incision, you have started the next section.
If we had done a primary and abandoned the case, this would have been a disaster. Always look at the scans, see all the levels from level 1 to 5.
And in my opinion, one of the other nodes which very easily tend to get missed is intraparotid nodes. Intraparotid nodes is one of the nodes which can tend to miss.
Especially at the tail of the parotid,
there could be a node which is very evident in the scan, but we usually tend to miss it.
The question of unresectability or inoperability, rather, should I say, that you've gone in and then you have to come out in head and neck is very rare, and whenever that happens, it's probably because we have missed the obvious.
Yes.
It is never obvious.
So radiological evaluation plays a biggest role here.
Not just doing the scan, but actually sitting down and reading the scan with your radiologist. That is
it's called a rookie error. A rookie error. So it's the basic level mistake.
So what I'd like to tell the residents and fellows here is that never look at the reports.
Always read the scans yourself.
Because you will, once you read the report, you will start seeing what is written in the reports on the scans. It may or may not be there. So first see the scans yourself, try to interpret yourself, and then go back and see the report and discuss with your radiology colleague, your residents or consultant, whomever you can catch. And that's the only way you can learn how to read a scan. Books are there to help you, but reading the scan from the films or the console is a different thing altogether.
So level 1B making unresectable is hardly ever, because even hyoid can be resected, the reticulum. Level 4,
it's a
not
question.
Sure.
Yeah. So if surgery,
multiple factors will come here in 1B and level 4. When you're doing with 1B, you have a wide exposure and the field is exposed. You can resect whatever, like you have a reconstruction options. But when it comes to level 4, the exposure is narrow and very close to the great vessels. So you end up in messing up with many things there.
And you end up in big catastrophe also. Yeah, so now coming to the next question. If surgery, are you worried about the nodal spillage? Now let us say the node is spilled, there is a macroscopic spillage. Does it influence the loco-regional survival or loco-regional control? Dr. Sandeep? Me.
Actually, I am not aware of any prospective trials that have studied that, but in our routine clinical practice, if ever there is a spillage, we do in the sense that there would have been spillage and there is a chance for loco-regional recurrence, we would give a thorough wash. That is what we would do. And we add betadine also. It obviously we do not know whether it is going to kill the tumor cells or not, but somehow that is a practice that has been followed.
Mahesh sir, anything?
So basically, it's just like adding Ganga Jal to a patient who has died. So
we
it's
don't
like
know
we don't know exactly.
So the point of bringing these situations has no guidelines or specific this thing. So we can only get an expert panel opinion. So that's why these situations are not very uncommon.
So the thing is that the patient already has extranodal extension. So probably it's part of that. But we need to take, so again, when there is a fungating lesion or a fungating node, we should tell our residents and all that not to keep touching the node all the time. Just put a gauze or a lint piece on top of it and don't keep touching the node and all that. And if there is a spillage, you should stop, just give a wash at that particular moment and then go back in. It's no point just, there's a spillage and you just keep operating. Just stop, get it cleared, go back in. Try to avoid it as much as possible, but with this kind of nodal burden, it's going to be difficult.
And any specific technique to avoid the nodal spillage? My next question. Any particular techniques anybody has to avoid?
Stick to the facial cleanse.
Meticulous dissection. But
still, if there is extranodal extension, you may not, especially when you are clearing from the great vessel, you may breach the.
That's what.
The thing is, meticulous dissection. While we're doing that, we tend to put too much pressure on the node. So that itself will, give rise to some spillage. So we have to take care of these minor issues, but I'm not sure there's any right or not perfect technique for this. I'm not aware of one.
So if there is a spillage, how do you want to manage it? In the sense, you want to get a betadine wash or
we used to put a betadine soaked gauze piece and suturing all around the fungating mass. That was the technique that we were following. But how much it is really beneficial to avoid the spillage, it's very difficult. That's how we learned, and we were, before doing neck dissection itself, we used to suture all around the fungation with a wet betadine gauze, 2-3 layers, and then we used to proceed.
So the tumor microenvironment, as you showed in the previous picture, it has breached the cortex, medulla, it came out. That microenvironment, everything is altered.
It's disrupted.
So such tumors, when the primary is bad, the node is so bad, we have operated on these patients, and there was a joke in the operating theatre: shift the patient straight from the OR into the radiation therapy suite. That's the kind of disease, and some of them used to say that I can already see the recurrence.
So me and Karthik keeps talking, let's give a cisplatin wash and then manage it.
So also one more point for residents, if there is a node spillage, some people I have seen, they try to take sticks through the node, but unfortunately that will make it more worse. So we should ensure that, first of all, most important point is be meticulous, and if it happens, sir, would you suction the entire node out, or yes? So it should not.
That's a good, actually, evaluate this thing.
Yeah. So some people I've seen poking it and then suctionating out and making it less this thing. So yeah, just to read.
In fact, we have seen patients wherein patient's note says that the patient had undergone IND before coming to us. So actually, it is not an abscess; it is the necrotic node which has been sucked out even before the patient is come, which is not to be done.
Maybe you can have that complete exposure, then you start dissecting the node, have that superior control, nice
inferior control.
Right. If you want to sacrifice the sternocleidomastoid, clear it off, then come on to the great vessel.
But invariably it happens. But unfortunately on the table it invariably happens when the surgeon is holding the specimen in his hand. When he is applying traction, he himself will be the person who will be spilling it all over. Necrotic tumors are very soft, they are pliable, and if it is necrotic and its kidney has breached, there is no way you can blame anybody, definitely not your assistants. You can't tell them to hold it softly or do this or do that. It is going to happen. There is nothing wrong in sucking it out and washing it even before you open the wound. In the past, some years ago, we were actually washing this with distilled water. Hypotonic solution would actually swell the cells and kill. Then somebody said that you actually put betadine. So everything has been actually tried. Nothing has helped. Ultimately what it means is just wash it out, keep it clean, and don't squeeze it. Be very gentle with the tissues. Cover it up well so that it does not spill over all over the wound and contaminate. But one thing is, if it has reached that stage, certainly you will be cutting through the lymphatics and all the tissues. Every bit of that will have tumor cells. So you are not going to sterilize the area, it is not possible. In any case, if you are doing this surgery, it is palliative.
Also,
so the thing is, you have ventured into it, complete it properly and close it, that's all.
Yes, sir. So also what sir meant, one important point is we also need to remove the lymph nodes en bloc. In such situations, we should not just cut out one single level and leave the node, we'll remove it later. That should not be done. We have to take the entire node also en bloc.
Even before the Bernier and Cooper trial got published, even in 80s and 90s, they used to give adjuvant chemoradiation for this reason, for extranodal extension. That is, the tumor has spilled beyond the nodal mass.
Nodal mass.
I mean, when there is ENE, that means the tumor is beyond the nodal system.
Right. Right. Let's go to the case 2. Yeah. So my second case is a 65-year-old male, smoker, good performance status, diabetic. On which he has a carcinoma of right pyriform fossa. No airway issues, he is able to eat well, no dysfunctional larynx, thorax is normal, CT3 and 3B M0. So if you actually see the scan, so carotids are good, divided, left IJV is seen, but right IJV is thrombosed. Again on left IJV is seen, right IJV is thrombosed. So my question to the panel comes. Is this a situation IJV thrombus makes it inoperable, or should we go ahead?
My question is, would you not consider, this is hypopharynx, it is T3 larynx, why not consider NACT followed by CTRT? Provided if the patient has functional larynx, you said patient has no breathing issues, patient is able to swallow well, and in that case I would be considering doing NACT followed by CTRT, because if you look at literature, the only site in the head and neck which has conclusive evidence whatsoever for NACT is hypopharynx. So we have evidence saying that there's benefit, so I would rather
so
ask
I'll come to that,
question.
sir. I'm coming to that, yeah. So does the IJV thrombosis is equal to M1?
Not sure. I don't think so. There's no evidence to say that. Provided if you do a PET scan, again I will consider doing a PET scan here, and there is no distant metastasis anywhere.
There are no distant mets anywhere. PET is clear. But do we, back of the mind, consider it as it's equal to like how this thing, like other systems like HPV or renal cell carcinoma. I know this biology is different. Everything is different.
In squamous cell carcinoma, there's no reason to consider this as M1. There is thrombus because of the node, so it is like N3B, and we treat it like that.
N3B, okay.
Would you consider a split therapy for this patient?
Not at all. So this is T3, N3B. So give NACT, assess the response, and then take it from there.
So if the node doesn't respond well, so would you do a RND followed by CRT?
See, split therapy is very clear in literature. Split therapy has not shown any survival advantage. So in fact, some may argue against the point is you're delaying the definitive treatment by just doing the primary, the nodal dissection. This is an advanced nodal disease. So again, it's the same question of the case 1 that will come up here. So rather I would consider giving chemoradiotherapy with this definitive and do a salvage neck dissection if necessary.
Dr. Sandeep?
From what I've understood from my general surgical oncology colleagues is that even in RCC, even if it has spread along the renal vein, they tend to resect it. So they do not consider it to be M1.
M1. And RCC is a different biology altogether.
Yeah, so that's another thing.
So that's what.
And they
subsequent
tend to
questions
have
are based
they tend to have thrombosis due to the disease per se. The disease is going into the thrombus. Here, the thrombosis is because of the nodal mass that is there. So compression. So two different
scenarios. So now next question: does your level of thrombosis influence your treatment plan? Let us say the top of the IJV, there is one patient has on the top of the IJV, second in the middle, and third is in the right lower subclavian column. I mean, not confident, just in the level 4. Dr. Manish Maisa.
Not that it is difficult.
So
thrombosis.
in the middle of the vein, do you want to treat in some way, and up and down you want to treat in some other way?
Okay. No, I think it is important to do a PET scan. I think I completely agree with what Shiva sir said. I feel in SCC we don't see node going into the vein that much as what we see in papillary thyroid and things like that. So whether it is compression and PET uptake is negative, then probably if it is if you want to give CTRT or resectability depending on the primary site, T3, T4, we should go ahead irrespective of the thrombus site. But if the PET an obvious uptake in the vein, which is lower down, with high chances of it going into the subclavian and not resectable, I think we should consider that as a palliative situation. I mean, in any case, this is a palliative situation because the disease is so aggressive with pyriform disease. So, yeah, but I think we should go with what the guidelines are, depending on what the disease status and whether that thrombosis is a disease or it's a compression.
So it's the same situation. I mean, the same scenario with 3 different situations can change the treatment plan. Yes, sir. Sure, sir.
Dr. Sriram, is primary, is it a T3 disease of pyriform fossa?
T3 disease of
Can you able to close primarily?
Yes.
Is it possible to close primarily?
Yes, sir.
So when there is an aggressive nodal disease, Dr. Shivkumar, what you said NACT, okay, that I agree. Suppose if you counsel with the patient attendants for the primary surgery followed by adjuvant radiotherapy, why can't you do a laryngectomy, partial pharyngectomy, R&D, and then followed by post-op adjuvant RT? Why not? So if the patient accepts.
So the thing is that, sir, I agree that maybe one of that it's not that it shouldn't be done. That is also recommended in the guidelines. But if the patient has a functional larynx, which he doesn't have, he's not tube dependent, he's able to breathe normally.
No, I am mainly recommending laryngectomy for the sake of thrombosis and the nodal disease. If the patient accepts the scenario, the prognosis wise probably this is a better option than sandwich type of treatment.
No, the sandwich type of treatment we are not recommending. We are either recommending chemoradiotherapy, NACT followed by chemoradiotherapy or surgery. So if it was, if you look at evidence, we have evidence. Of course, there's no direct head-to-head comparison of upfront surgery followed by CTRT versus NACT. But given the fact that this patient has a high nodal burden and there's thrombosis, so that is why we have evidence to give NACT and CTRT, because the resectability is also is under question here of the nodal disease, not the primary per se. And we can counsel the patient, and if the patient agrees, and if the patient is known to me, I would want the patient larynx to be saved more than anything else. So it depends what the patient wants at the end of the day.
I think it is so unpredictable how the chemoradiation is going to act on the larynx, and we have seen some amazing results. So I think if we can preserve an organ, will be better than going ahead with surgery, and always salvage surgery is always possible in most of the cases.
Well taken. So this is one paper which everybody can look into, IJV, but as the panel said, the thyroid associated with IJV thrombus is much common, but again SCC and thyroid, the biology is too different. So in the case of thrombosis, always histology plays a big role. So we already consider NACT.
I think I would recommend all the residents and fellows to read one paper by Blake Caddy. It's in the Seminars of Oncology, wherein in that paper he just talks about in general about surgical oncology, how it has evolved, and in that he clearly mentions that disease biology is the king. Biology is the king, and the surgical maneuvers are the prince and princess, and many times they try to overthrow the king, but they end up biting the dust at the end of it. So this biology, whatever is said and done, we can remove it, but it's as what Manish said, it's unpredictable. It's the disease biology that has the last laugh.
Any role of thrombectomy in these situations? Anybody has any experience? Not in SCC. So I'll come to that. So what about adjuvant for these patients? Now let us say adjuvant chemoradiation in these kind of patients. So
that is that adjuvant in the setting that you have operated on.
Yes.
Then definitely there is radiological, definite pathological evidence also would be there of external extension. So that would be an indication for adjuvant chemoradiation. But in my book, I would agree with sir completely. I will not touch such a case where larynx is functional and there is a potentially inoperable node.
So if now let us say both it was completely inoperable in the presence of an IJV thrombus, let us say it was at the confluence of IJV and subclavian. What does the radiation do to this thrombus? Can we radiate, or is a double-edged sword that we can now migrate? What is the
whether you remove that thrombus or not, the disease has already migrated. It's gone beyond your control. So, and if you see a thrombus at the IJV subclavian junction, you have to ask what the intent of treatment is first of all. And I'm not sure. And in squamous cell carcinoma, thankfully, we don't see such a situation. Just the thrombus is there and the node is resectable. I'm yet to see such a situation. You will have a node which is unresectable, and with that there's a thrombus. That is the common scenario. And even if there is a resectable node with a thrombus, that is because of the nodal compression rather than the disease going
direct infiltration of the node.
And for squamous cell carcinoma, there is no role of thrombectomy. Even for papillary CA, which is with thrombus, when you do the neck dissection, you can see the thrombus going in. You just need to have vessel control and try to get the thrombus out as much as possible. And you can see very well as to how far inferiorly the thrombus is going in a papillary CA thyroid, because it is mostly enhancing. And you would have to have vascular control, thoracotomy if needed, and you'll have to go in that direction rather than anything else. So for squamous cell carcinoma, I don't think so we should do all
this
of
thrombus issue comes only when we are doing a salvage neck dissection. As he said, with the upper end, sometimes upper end ligation of the internal jugular vein may be very difficult because of the presence of thrombus. So sometimes if you remove the thrombus, we can easily ligate the upper end of the internal jugular vein. Otherwise, the thrombus issue is not an issue at all in squamous cell carcinoma of the either hypopharynx or even glottic tumor. We have not come across this thrombus issue at all, unless if it is going too much to the upper end in a salvage neck dissection.
So these two papers you can refer from IHNST group, occlusion of IJV in well differentiated thyroid carcinoma. They give different situations of thrombosis. You can go through that. And again, you should be aware of ring sign. The outside vessel of the IJV with the ring. These patients are suitable for thrombectomy. Possibility of removal of thrombus through venotomy and thrombectomy.
I think we are confusing two things here.
Yeah, we have SCC and yes.
Actually, this shouldn't be coming in the discussion at all.
Got
because we should restrict our discussion to squamous cell carcinoma.
I get it.
Because we are showing two different things, and I think the message that goes across might be confusing for the residents.
So that's why this is for thyroid and not for squamous cell carcinoma.
Thyroid with thrombus is a different thing altogether.
Body, yes.
What recommendations are the images for thyroid, and that too differentiated thyroid cancer. And not for medullary thyroid, anaplastic thyroid, it's as bad as squamous cell carcinoma or even worse. So, and for squamous cell carcinoma, this question rarely arises, and it, as what Nanjana sir said, you are looking at the upper stump, if the disease, and you don't get a situation where it's a resectable node and there is a thrombus and you're looking for a thrombectomy. That situation doesn't arise in a squamous cell carcinoma. So please keep this in mind.
Right. Next, the plastics surgery part, Dr. Radhika will take over. Thank you.
Good evening, everyone. So here's the outline, what we are going to see. So this is a base of tongue resection defect. What will be the choice of reconstruction? Soumya ma'am, pedicle flap or free flap, and what will be the options?
This this a resection with mandibulotomy?
Yeah, with mandibulotomy, it is BOT.
Okay. Looking at the contour of the defect, I think
my question would be whether it is per primum or salvage setting.
yes.
And based on that, we need to decide how to go ahead.
How to go ahead.
That's the first question, and next question
Next
will follow.
question is what is ideal?
It is per primum, okay.
So then a thin pliable flap to go through, go around with that inset. And I think Dr. Prashant has some experience doing the reconstruction post-robotic resection of such lesions.
This is fully open.
Yeah, this is fully open, but even when it's not.
This is fully open. I think we can use a thin pliable flap.
Mm-hmm.
In fact, if you, I think the free flap options will be the best one. And nowadays we are using skip flaps very extensively. Skip flap is very thin, and considering the defect, I think we don't require a very long length of the pedicle for this reconstruction.
Okay.
I think the defect may be almost reaching the neck. So we can do a skip flap, or alternatively we can do a radial forearm, ulnar forearm with the flaps.
Okay.
Thinner
So
flap will be better. ELT may be more bulkier.
Both the lingual arteries are hit.
yeah, that's what I wanted to bring into light. That there is little bit of tip discoloration, and the way they have undermined it, it looks like the opposite side of the lingual artery is also gone. So if this kind of situation is there, that on table only you are seeing that there is bluish discoloration after tongue resection, what is your approach?
So we've done a few cases with a flow-through radial forearm
Yeah.
flap where the distal end of the pedicle was anastomosed with the lingual artery.
But what if you don't find the lingual artery over there?
That is a different thing. I mean, so there the viability of the lingual artery was intact at least on one side. Here, because
Both
of the
sides
discoloration, it looks like both sides is questionable. You need to be sure as to whether your
The discoloration, this is more of a congestion. It is more of a venous issue. The discoloration is more of a venous issue. It could be because of arterial also. I'm not denying that. So I think if we are definitely sure that ulnar artery has been injured, and I'm not sure whether the neck dissection has been bilateral in this case, could be bilateral because it's across the midline. And if you're sure of lingual artery being injured, and if you have stumps, I think we can reconstruct that and we can go back.
Any role of ICG, intraoperative ICG?
Yes, yeah. But ICG is more for arterial problems, not for venous. In fact, ICG, if you do it, if you get a perfusion more than about 45 to 50, it says it's more of an arterial problem. It cannot comment very definitely about venous problems. So this venous problem also could be because the stump of the base of the tongue stump that is left back may not be adequate enough for venous return. I think there are both components. Dusky discoloration is more of a venous problem than an arterial problem. Of course, arterial problem could be there along with this.
So for tongue, as I do agree that there is definitely a venous component as well to this, but here in tongue you don't really, the main issue here is the arterial blood supply.
Yes, I think we can consider it, the issues are if you do not know what exactly is the condition of both lingual arteries, I think we can proceed in 2-3 different ways. One is you can give it some time, because over the time the vascularity, we can understand it much better. We can plan for a delayed reconstruction. If you want to, of course, if you are looking at doing the things in a first go itself, I don't think we can go, I think it would not be a better thing to go and do a total glossectomy just because of this. I think we can definitely wait for some time.
The other thing is, I'm not sure what the consenting is.
Yes, that is.
Was the consent for
Yes.
total?
Yeah,
Yes,
that's what I
yes,
wanted to
yes,
ask.
So
yes,
if
yes.
it is not taken, then
Yes,
definitely we
and
should
if
be
you are afraid of having a fistula, orocutaneous fistula, or then we can just probably do a PMMC or probably a PMMF, so that we just seal the thing off. We can come back and assess the defect, and we can plan the next kind of treatment.
And sometimes in hemiglossectomies also we see that the tip gets discolored on the table itself. So in that cases, like sometimes we decide that okay, let us wait and watch. If need be, we'll discard it in the ward, and for that purpose maybe while harvesting we can take 2-3 centimeters of extra flap and maybe ignore that the patient is going to bite on the flap and anticipate that bluish discoloration and later discard it and feed the flap and complete the inset.
In this case, it's not the main lingual artery which is probably hit condylateral. We have the deep lingual, sublingual branching pattern happens. So it's not that the complete native tongue will go.
Okay.
So that we need to keep in.
Please finish. Yes.
So, point taken, Kranti, but it depends that the other branches supplies the base of tongue. And actually for the anterior 2/3 is predominantly the lingual artery. So that is where the discoloration is.
I think I just want to add to this point. We had a situation where previously operated patient came for a toss, and during surgery, I think they ligated the lingual artery. There was gross discoloration of the tongue, and there was a question as to how we should be proceeding. And ICG showed a perfusion, but it was very concerning that bilateral linguals are gone, still the tongue would survive or not. What was done was we did a ICG, the perfusion was alright, but we just cannot believe ICG because sometimes could just be a early glow and later on it could go for necrosis. Nothing happened. I think it probably survived based on the collaterals because previous surgery was happened, some amount of collateralization might have developed and that would have probably helped the tongue to survive.
So was that similar anterior 2/3 that was discolored or was it base tongue?
No, a significant base tongue was removed, so it was more of anterior third which was left behind. Yes.
Okay, thank you everyone. We'll come to case 2. This was a case of near total glossectomy. We had reconstructed with a free anterolateral thigh flap. On day 9, along this area, the intradental sutures, morning rounds we went and we saw that till this area at least there was some bluish discoloration. We waited till evening. We thought that, it is maybe because of the tight suturing and all. OC was ruled out, orocutaneous fistula was ruled out, the drains were absolutely clear, the neck was flat, but by evening when we went for rounds, we got this surprise. So I want to know that on day 8, day 9, what is the role of intervening in terms related to microvascular salvage? Like, will you take the patient back to the OT, will you open this, or you would prefer right away doing a free flap? Another flap, not a free flap, another flap.
So, there's no role of taking this patient in for revision of microvascular anastomosis for sure. So you just have to wait for some more time for the flap to demarcate and then go in for a formal debridement and take care of whatever is left. So usual scenario is that this kind of a defect would be plugged in with a PMMF or something like that.
We did a PMMC later.
So if partial flap is left behind then?
I think the infection may not really manifest with a gross swelling. There could be some amount of subclinical infection.
Okay.
So the discoloration, most of the time the delayed flap losses are because of infection, most of the time.
Yeah.
And considering the day, that this is being a day, I think 8.
Yeah.
Yeah. Usually the maximum swelling usually happens between 4 to 6 days.
Yeah.
The maximum swelling. And if you do not have a perforator in the anterior part, and if there is a gross compression, you may end up losing the tip of the flap. The rest of the flap may still be alright. So one of the things that I tend to do whenever it's feasible is that try to have 2 perforators, one at the base and one more at the anterior portion. So that anterior portion gets a separate blood supply. In fact, the posterior portion should also be able to supply this. In case there is a gross swelling, that portion has a separate blood supply on its own. So we can wait and watch. And if things really say that it's not going to survive, probably you can go and do other flaps.
Manish sir, can you please comment about this? What is your approach to these kind of issues? On day 8, 9?
I agree with Soumya. What she suggested is first to let it demarcate to see whether how much flap is going, and depending on that defect, we can decide further a reconstructive option. Obviously, with day 8, day 9, flap failure is always going to be difficult to get a good vessels in the neck to do another free flap if this failure happens, unless opposite neck has not been addressed. But obviously, it's a total loss, so bilateral neck would have been addressed at that time. Other thing is, we routinely, probably if we suspect a subclinical infection, we would do a CT scan. If we can pick up infection, probably for drainage of that infection, would be a good idea to see if any compression on the pedicle or on a perforator can be reduced and flap perfusion can be restored.
Okay, so we'll go to the next case. Thank you. So this is a central arch defect, very commonly done. So I'll directly go. We've discussed about NACT in the morning, but I would really like to know Soumya Madam's and Prashant sir's perspective in post-NACT surgical fields and the quality of the vessels. Ma'am.
So we do have quite a bit of experience operating on post-NACT patients. I think one is that the vessels tend to be a little more friable, tissue tends to bleed easily. So all the steps that you do routinely, this is something that I keep telling people who are in training, that there are certain steps that you must follow for every flap, so that when you're encountered with a situation like this, it doesn't become something new that you're doing. Um, Limited tissue handling, limited vessel handling during anastomosis are practices that should anyways be there, which will eventually help you in a case like this. You will do 99 cases where those steps wouldn't really matter, but that one case where you had to be really careful that you didn't handle the artery too much so that you set it into spasm or things like that, these are one of those cases. So of course, treatment wise, we let the head neck surgeons decide what needs to be done. And in these cases, you have to account for larger resection, so adequate flap cover and not too tight inset sutures, because everything is going to swell. So if you take very tight inset sutures, that will end up in marginal necrosis. And make sure the lie of your vessels are good. Don't aggressively dissect out your recipient vessels. Try to do endoside anastomosis where the vein is concerned. And your arterial anastomosis should go in a single go with absolutely, no flipping the vessel back and forth, no unnecessary handling of the vessel. And these are cases that almost always we would put papaverine over the arterial anastomosis post that.
I think I agree with what Dr. Soumya said. The other thing is that I think compared to, I think the most difficult surgeries are with breast reconstruction, DF after doing a NACT. Compared to that, I think head and neck is still relatively better with respect to handling the vessels. And of course, due diligence with handling of the perforator. If you're planning to do a perforator based flap, try to take a small cuff of the muzzle. And I think from the starting of the incision only, you will realize that this patient is going to be very fragile. The vessels are going to be very delicate. I think at that point of time only we can decide. So we can try to have some muzzle so that the handling is better. And I think most of the time, it's whether it's just a NACT or whether the patient had received any kind of radiation in the past. I think radiation may be more difficult thing to manage, because sometimes it's so badly adherent that you end up damaging the vessel during the dissecting that hard fibrous radiated block than the NACT. But of course, compared to per primum disease, post NACT the vessels are they require better care.
If you are planning to salvage this flap, would you use the ipsilateral neck vessels? When I was doing this case, the ipsilateral neck vessels, they were repeatedly going into thrombosis, so I decided to go to the opposite side. There also, nothing was happening. Then finally,
you had a problem with the flow, or you had
there was no flow in any of the vessels.
Yeah, that's a very common situation actually. I think especially I find this with post radiation. But the thing is that I tend to do the arterial anastomosis almost like an end to side. May not be exactly end to side to the external carotid. So you usually you go almost maybe about a 0.5 centimeter, or maybe sometimes 1 or 2 millimeter of the superior thyroid origin or facial artery origin. Usually at that point of time, I feel there is no flow is still good. Sometimes even about 1 centimeter across the origin also you may not get a good flow. Going more towards the ECA, even though it may make the surgery anastomosis more difficult, I think you are more sure that the blood supply through that vessel, it's almost like doing an end-to-side. And I think external carotid should have a good flow. In case it's not, even if you're not having a bleed, I have a few instances used distal ECA as an end-to-end. And I think that's probably not the best thing to do, but in those situations you're looking at only the flap to survive and you want to tide over the situation, so I think you would go for that. Yeah.
Okay. So this is a large buccal mucosa defect, mandible, maxilla plus ITF clearance plus skin defect. Which is the flap of choice? Prashant sir.
Right now, for one-sided mandibular diseases with extensive soft tissue volume, I think even though maxilla is a bony defect, usually even with even regular practice also we are not reconstructing separately mandible and maxilla. So for ipsilateral one-sided mandibular defect with extensive soft tissue volume, whether there is an external skin defect or not, our first choice of flap is scapula. Now I think that's in fact our scapula numbers are probably more than doing a fibula flap, because we tend to get more of ipsilateral defect. The main reason for choosing the scapula is that it can provide a tremendous amount of soft tissue, and in case the bony requirements are not very large, we can manage these defects with a single flap. And the scapula vessels, the circumflex scapula artery, is less likely to be sclerosed compared to the peroneal artery, even though the pedicle length may be slightly shorter. And if you talk to the head and neck surgeon, if you ask them to leave 1 or 2 vessels extra, I think we can do the anastomosis also much more easily. And it's a very robust flap, and it can fill, I think, each and every crevice in that defect. And healing wise also, it's much faster. And you don't require a skin graft in the fibula donor site, and the patient can be ambulant by next day itself. And shoulder morbidity is not high with the scapula flap. So I think it's a great flap. And so any dissection of this sort, we do a scapula as a first line.
Is putting a bone flap required here? I mean, because it is a posterior segmental mandibulectomy, which is not crossing the midline.
I think there is different opinions. Some people would say, if you are going to only till the level of the molar, you can probably, the mandibular occlusion changes may not be much. So if you're crossing some, say, first molar, second molar, so say first premolar, second premolar, the chance of mandibular deviation starts to increase. I think you should look at what level the mandibular cut is. And if it's a truly posterior segment, like only if it's just 1 or 2 molar teeth and the ramus, I don't think it would affect the occlusion. So you can always go back with the soft tissue flap like ALT also. But if it's more anterior, I think it was better to have bony reconstructed, especially if the patient is young and if the resection has come out really well.
Manish sir, your opinion in such cases, whether bone flap is actually needed or not, sir?
Yeah, I think we will always do replace a bone with bone. So if as he suggested, scapula is a good option because the bony length required in this case is pretty small. If the bony length is required is big and the skin defect is big, we don't hesitate to do a double flap as well. But I think scapula is a good option in this case, I suppose.
I think Soumya would disagree. Probably she would do 2 free flaps because she has a luxury of
10 residents.
I would do 2 free flaps only for the reason that I can harvest both the flaps prior to the head neck surgeons moving out. That is primarily the reason.
That is a very sly remark.
So waiting for the entire resection and neck dissection to be done, flipping the patient over, it's just logistics, that's all. Especially when you have to keep doing this every day of the week, that's the only issue.
If logistics are not an issue, then scapula, you would agree, ma'am?
For soft tissue components, definitely scapula is a very robust flap, and in fact there have been multiple studies done on patients with peripheral vascular disease, and the thoracodorsal axis is the only axis that is somehow spared of all the ill effects of calcification in such patients. With regards to whether a pedicle flap or a free flap, I think Dr. Shiva's study results are awaited on the same. So we'll have the answer probably by the next year or so.
So if we leave this ITF area raw, what all can go wrong? And in short term and long term both?
Raw
To
as
the
in
head and neck
without a
surgeon.
lining or without film?
Just like if we are opting to do PMMC, they are saying that the prognosis is bad or the ENE positive node is there, then you cannot do a free flap. And if it is a salvage case with the vessel depleted neck and you do a PMMC.
It depends on whether the skin defect is there or not. If it is a single paddle defect, I think PMMC should suffice. But if there is an external skin defect with an ITF defect, I don't think we should plan PMMC.
If only
not that we don't do PMMC, we do PMMC, but I think you should plan free flap for such large defects because the soft tissue component in the skin defect is so large that PMMC may not suffice. Because skin paddle will take up most of the PMMC and the ITF will be left. The muscle paddle will not reach the skull base.
Understood.
To the panel, there seems to be soft palate involved. So how would you reconstruct the soft paddle when you have such an extensive defect?
All the more reason not to plan PMMC in this case.
Yeah.
So when a decision has already been taken to operate or resect, I don't think then the what is the prognosis of this patient should matter. We've already decided to resect the lesion. So then everything that needs to be done in order that adequate reconstruction should be done has to be offered. There is no question about that.
Yeah, I think if you are really considering because doing only PMMC, and if the donor side is quite bulky, and you can take a slightly longer flap, the distal part you can kind of deepithelize and then try to fill it. But I think leaving the ITF and those areas without any fill, I think will lead to seromas in the long run, and they invariably get infected. It goes down, and it's a problem. I think it's going to be a problem. So some form of fill, I think, would definitely merit that.
And the other problem is these patients will end up receiving chemoradiotherapy. And if
Chemoradiotherapy.
you're not packing this with adequate soft tissue, then what happens is many patients come with this hollow, and there's and this bone is exposed.
Bone gets zygoma gets
that
exposed.
undergoes ORN, and there's a constant
Yes.
discharge that's coming. So all that can be probably avoided.
So
And soft tissue, soft palate insert. I think if you understand the physiological basis of soft palate reconstruction, I think it's both sides of palatal muscles getting inserted into soft palate is the basis for a normal palatal function. So, and since we cannot be doing that, I think what we can try to do is at least feed some extra portion of the skin there, so that you try to reduce the dimensions of the velum. But all said and done, we have seen these patients do not do really well with, especially with the speech.
What we have seen is we take an extra segment of skin panel, deepithelize it, bring it back, and that deepithelialized segment will be acting as a second layer, and you suture it to the soft palate. Even we have done it in case of PMMCs also.
Basically, try to reduce the dimensions of the velum so that you can do the best possible.
But when
Keep it a
PMMCs
bit tight rather than flabby or floppy.
So in this case, we did an ALT since it is a posterior mandible not crossing the midline. We did ALT with muscle, deepithelialized, and we brought it out for the outer skin cover. Other question is, if it is an extended hemimandibulectomy, when will you go for a free like a fibula where you with an intent to support the tongue? What is that cut? I mean, is it the opposite side, premolar or incisor? What is that cut? Till when we can only get away by using a soft tissue flap and support the tongue as well?
basically here for the extended hemi or whatever you are asking, we need to have the genioglossus support. That is most important for anybody.
Okay.
Like even we doing the reconstruction. If we lose that, then that tongue tends to fall back. Both the genioglossus, if tend to fall, it is.
So it is not just about the bone; it is about the floor of mouth muscles as well.
And also whether it
I
is
think one of the important point I feel is that we have to be, while resecting the tumor, I think if we can save some centimeter of the upper part of the condyle to at least get 2 screws, it will make such a huge difference in terms of the outcome. So I think if that is possible, which I think it should be possible in quite a few cases, because even if the ITF is involved, normally the TM joint is not involved.
Yes.
So if you can get soft tissue around it, and then if you can save it, that's one of the very good things. In Coventry, few people have also tried using. We always do a 3D planning for all these cases, and they have planned the TM joint as well. But I think that does not work because of radiation in these cases after the surgery, which lead to a lot of fibrosis, and finally the function was not very good. So they've stopped doing it. But I think if we can save some part, if we can get 2 screws of the plate, it will make a huge difference.
Yeah, Manish, I would also like to comment. Only if it is oncologically feasible, and secondly, yeah, it is a technique which we also practice. Cut above the zygoma. Cut above the neck sigmoid notch. Preserve only the condyloid process, and it's easier to do an ITF clearance when you do that. As you go deeper, you hit the greater wing of the sphenoid, the skull base. So you can do a formal ITF clearance, removing the insertion of the lateral pterygoid also, but you can preserve the bone. But the bone will not have much of soft tissue covering around that. But the TMJ will be intact.
the other point I wanted to make was whether this case is being operated upfront or whether it is in an already irradiated neck.
This was upfront.
No, meaning to say your reconstruction of whether you want to use a fibula, it can matter, because if it is already patient has been irradiated and all that, there'll be so much of fibrosis that is there, and adding a fibula may not, doing a fibula may not make much of a difference. So then a soft tissue flap with so much of area to be covered, either you do a soft tissue flap or you do a double free flap. That call has to be taken intraoperatively.
If the patient gets radiation, most of the tissues are scarred. So the degree of lingual tilt of the residual mandible will be lesser. It may not be severely restricting. So we can still consider a soft tissue flap.
I think one more thing, I sorry if they have time. I think we talked about using the digital ECA. I think we don't hesitate much to use it. We just go high up as possible if the vessels are not very good. Because I think the first chance is the best chance. So if we get the high end of ECA and get an anastomosis as well, that's fine with me. And post RT, I think what is important to understand is before we raise the flap, I think we should check the neck vessels. If the neck vessels are good enough, then only we should raise the flap, otherwise we should do a pedicle.
One issue with distal ECA is that the scalp will go for a toss if you are planning on salvage. God forbid if the flap should be.
You have more plastic than us.
That's good to know. Okay, we can wind up, I think. Thank you, everyone. Thank you, Manish sir.
Thank you.
Thank you, Manish.
Thanks.
Nice.